Hey everyone, today I'm diving into something super important. Hypertrophic cardiomyopathy, or HCM. Ever heard of it? If not, stick around, this could save a life. HCM is a genetic heart condition that makes your heart muscle thicker than normal. Imagine your heart working overtime like lifting weights 24/7. This thickening usually happens in the left ventricle, the heart's main pumping chamber, and it's not because of high blood pressure or another condition. It's all in your genes. So what's the big deal with a thicker heart? Well, it can mess with your heart's ability to relax and fill with blood properly. Think of it like trying to fill a water balloon that's too stiff. Sometimes it can even block blood flow out of the heart, making it hard for your body to get the oxygen it needs. Symptoms can be sneaky. Some people feel nothing at all, but others might experience chest pain, breathlessness, fainting, or in rare cases, sudden cardiac death, especially in young athletes. This is usually through an echocardiogram. That's an ultrasound for your heart and genetic testing. Once diagnosed, managing HCM involves easing symptoms, preventing complications, and cutting down the risk of sudden death. Medications, lifestyle changes, and sometimes even surgery can help. Remember, knowledge is power. If HCM runs in your family, talk to your doctor. Stay informed and stay heart healthy.
Hi, my name is Tasha and I'm taking Bachelor in Cardiovascular Technology. So for my topic of case study is hypertrophic cardiomyopathy. So hope you enjoy the video. My case study is about an 84-year-old woman with a history of obesity, hypertension, dyslipidemia, carotid atherosclerosis, and also COPD. She underwent a routine echocardiogram. So she had no chest pain, no palpitations, or also dyspnea at rest. So 20 years earlier, 10 years ago, she developed permanent atrial fibrillation, which was managed with anticoagulants. So in recent years, she experienced worsening dyspnea and limited mobility due to vertebral collapses. So a 2020 Holter EKG suggested silent ischemia, but coronary angiography ruled out critical stenosis. So in 2022, she was hospitalized for bronchopneumonia and worsening heart failure. So despite persistent high proBNP levels and a history of hypertensive heart disease with diastolic dysfunction, mild left ventricular hypertrophy questioned the heart failure's exact cause. So this case highlights the challenges of managing elderly patients with complex cardiac conditions, emphasizing the need for thorough diagnosis, evaluations, and personalized treatments to ensure accurate diagnosis and effective
So
care.
next is the echocardiography images of my case study. So it showed a mild thickening of the interventricular septum, where the septal thickness was 12 mm, the posterior wall thickness which was 11 mm, with a dilated left atrium at the antero-posterior LA diameter, which was 41 mm, and a hypernormal LV ejection fraction, which was 74%. So both ventricles were apparently of normal size. There was no evidence of wall motion abnormalities or dynamic left ventricular outflow tract obstruction. So as you can see from the picture before, my echo picture was not clear, so doctors assessed by contrast enhanced transthoracic echocardiography. So as you can see, it's a 4-chamber view. So before contrast, which is on the left, and after ultrasound contrast injection is on the right. So before contrast, the LV apical region does not show any clear delineation of the endocardial border, but reveals a fairly homogeneous low backscatter echo structure resembling a blood pool. So no evidence of abnormality of the LV apical region can be noted, but just poor quality imaging of the apical region with scarce delineation of the endocardium, where the pacemaker leads can be noted in the right atrial cavity. So the severe hypertrophy of the LV umbilical wall can be noted and measured as indicated by the arrows in the pictures, and also the left atrium is dilated and the right atrial cavities are filled with contrast medium. So next we have is the tissue Doppler imaging for my case study. So as you can see at the top, the tissue Doppler imaging of the movement of the septal, which is on the left, you can see the E septal wave, and of the lateral mitral annulus, which is on the right, which is the E lateral wave. So and then you can get on the bottom left is the transmitral blood flow Doppler recording mitral E wave, where the A wave is lacking since the rhythm is atrial fibrillation, as you can see in the ECG in the picture. And then the EE ratio is elevated, indicating a high mean left atrial pressure, confirmed by the elevated pulmonary pressure as assessed by maximum velocity of the TR jet, which is 2.7 centimeter per second on the bottom right picture.
Echocardiography examination, there was also ECG was done. So as you can see, this is a 12-lead ECG. So there was no typical giant negative T waves in this ECG. The rhythm you can see is an atrial fibrillation. The R voltage of the QRS is modestly elevated in V3 until V5 with only a shallow negative T wave in the V3. And also this ECG shows a placed QRS.
Timely diagnosis of apical hypertrophic cardiomyopathy, known as APHCM, using contrast echocardiography enables early interventions to prevent complication. Key treatment strategies focus on reducing fibrosis and hypertrophy through weight loss, diet control for hyperglycemia, and blood pressure normalization, potentially aided by ACE inhibitors. Avoidance of inotropic drugs like digitalized and the use of ICDs for life-threatening arrhythmias are essential. While genetic screening is not typically recommended, regular EKG and echocardiography evaluations for first-degree relatives are advised, with intensive follow-ups showing symptoms or abnormalities. These measures aim to improve patients' outcome and manage diseases progression effectively.
That's all for me. Thank you for watching.